Hey everybody, this is Rusty, and today we're going to talk about abdominal disorders, part 2 of 3. Primary and minimum assessment on everyone. You've got to do it. The primary assessment. You got that general impression, level of consciousness, threats to life, their airway, breathing, circulation, their disability. Look at D's, pupils, and expose D's, chest, so you can listen to 6 lung sounds and 3 heart tones. As you're moving from D's pupils to the chest, notice the neck and the presence of any JVD. Like I said, once you listen to 6 lung sounds and 3 heart tones, you need to do a pulse, motor, and sensory pulse wiggle feel on their hands and their feet. And then squeeze their ankles for the presence of pedal edema. Rule out any serious signs and symptoms: altered mental status, acute heart failure, JVD, chest pain, hypotension, and signs and symptoms of shock, and then do your initial paramedic care, that IV, O2 as needed, and ECG. After the primary assessment and the minimum assessment on everyone, we're going to do a detailed assessment of the abdomen. Number one patient. They're your number one patient this time, so have them take their number one finger and point to where it hurts. And then we're going to do an IAPP. We're going to inspect for that decap BTLS, also masses, distensions, pulsations, and stomas. And then we're going to auscultate. We're going to listen in all 4 quadrants for increased or decreased bowel sounds. You need to listen for at least 30 seconds per quadrant. If you don't hear anything, then they say to listen for 5 minutes each. However, we're rolling down the road in an ambulance, so the likelihood of you hearing anything further is slim to none. Then that palpation. You're going to start in the quadrant furthest away from where your number one patient pointed their number one finger. They're going to have them flex their legs and start with a light palpation of each quadrant. Then do a deeper palpation of each quadrant, and then look for rebound tenderness. You're going to push down and then let up quickly to see if there's any pain with that wave going across the abdominal contents. Let's talk about upper GI and esophageal bleeding. Pathophys, it's above the ligamentum teres, and causes are peptic ulcer disease, erosive esophagitis, esophageal varices, Mallory-Weiss syndrome, and cancers of the upper GI tract. So high risk populations are men and the elderly. Big signs and symptoms are hematoemesis and the hematochezia. Emesis is coming out of your mouth, coughing, vomiting, spitting, and hematochezia is out of your rectum, bloody poo. So, and there may be signs and symptoms of shock depending on how much blood loss has occurred. With the differential diagnosis, attempt to figure out if it's acute or chronic problem, how long it's been lasting. Did it come on all of a sudden, or has it been gradual onset? What's the color of the blood? Bright red, darker, coffee grounds, things like that. Get that pain scale, OPQRST, and figure out what increases or decreases the signs and symptoms and the amount of blood. For your treatment, basic paramedic care, IVO2 monitor. We will withhold fluids or restrict fluids unless this patient is in shock, pale, cool, and diaphoretic. So, and get them to the hospital for further treatment. Most common cause of GI bleeding is peptic ulcer disease. Peptic ulcer disease is caused by the H. pylori, little bug down there, and it causes 60 to 70% of those cases. Duodenal, gastric, and stomach ulcers are forms of PUD. Remember, the stomach is acidic and it's balanced by bicarb in the duodenum. Signs and symptoms. Pain subsides after eating. If you do your OPQRST, they may say the pain is a burning or a gnawing. in the stomach. They may complain of nausea and vomiting, burping a lot, or heartburn. Could have blood from the mouth, hematemesis, or from the butt, melena, and blood-tinged stool. If they've bled enough, you could have signs and symptoms of shock, pale, cool, and diaphoretic. With your differential diagnosis and history, key in on that pain before eating that subsides after eating, and try to ascertain how much alcohol they drink. Treatments are proton pump inhibitors to help reduce the bleeding in the acids. Avoid nonsteroidal anti-inflammatories, aspirin, caffeine, and alcohol. IVO2 monitor in the pre-hospital environment. Erosive gastritis and esophagitis. It's erosions or inflammation of the gastric esophageal mucosa. Causes are on our picture. We have wine, coffee, alcoholic beverages, non-steroidal anti-inflammatories. Signs and symptoms. They can complain of indigestion, heartburn, a lot of belching. They may say they complain of dyspepsia. Now, what is dyspepsia? It's an upset stomach for no reason. They could also have nausea and vomiting and a chronic cough. Differential diagnoses is tough in the field because the signs and symptoms are so mild. Pre-hospital treatment, IVO2 monitor, get that line, give them some pain control and some antiemetics if they are vomiting. In the ER, they're going to give them some viscous lidocaine, some antacids, and do further tests. Have the patient avoid nonsteroidal anti-inflammatories, aspirin, caffeine, and alcohol, all those good things that cause it. Esophageal and gastric varices. Varices are caused when blood flow through the liver is restricted, causing portal hypertension. That hypertension is normally associated with chronic alcohol use, and that chronic alcohol use is the most common cause of these varices. Varices are dilated veins due to that increased pressure that causes damage. Signs and symptoms can be gradual because you're drinking over months or years. Could be also liver disease, and the patient could be yellow or jaundice. They can complain of fatigue, weight loss, anorexia. They could have a ascites or an edematous belly, fluid in their bellies, pruritus or itching, abdominal pain, nausea, and vomiting. So differential diagnosis, you could mistake this as a peptic ulcer disease unless it ruptures. And then if it ruptures, you've got that dysphagia, and that is difficulty swallowing. They will be vomiting, and that vomit will be bright red blood from those ruptured varices. Treatment, IVO2 monitor, some fluid if they're in shock, and try to estimate a blood loss at the EBL. If it's internal bleeding, have you ever thought about TXA? They haven't done any studies yet, but it may be seen in the future. In the hospital, they're going to give the Stag-Taken Blakemore tube. It's basically a tube that goes in your esophagus and your stomach, blows up, and puts direct pressure on the varices. Mallory-Weiss syndrome are longitudinal tears of the gastric side of the gastroesophageal junction caused by protracted vomiting. So signs and symptoms can be mild to life-threatening depending on how much blood is lost. Hematemesis is in 85% of the cases. Some factors are they using aspirin? They drink a lot of alcohol? Or are they bulimic? Remember, those bulimic patients binge eat and then make themselves vomit because they think they're too fat. Some differential diagnoses, you might think it's esophageal varices or Boerhaave syndrome, and we'll talk about that later in the presentation. Treatments for Mallory-Weiss syndrome are IVO2 monitor, some antiemetics, and then when they get to the ER, they're going to do some gastric lavage and then put a scope down there and look around. Borhave's syndrome is a rupture of the esophagus caused by explosive vomiting, pushing during childbirth, weightlifting, seizures, and status asthmaticus. Signs and symptoms are diffuse and severe distracting pain. Oh, I've got this pain. It's way out of proportion of what they present. That pain could be in the chest, the neck, the back, or the stomach. They could have difficulty in breathing. They could be tachycardic on the monitor and have hematemesis and vomiting up blood. If the pain is in the neck and the tear is in the neck, you could have subcutaneous emphysema and that crackling. So differential diagnoses, a Mallory-Weiss tear, peptic ulcer disease, or it could be so bad you may think it's a myocardial infarction. Treatment, IVO2 monitor. Remember, with this syndrome, there's a 50% mortality rate. So that index of suspicion needs to be high or they'll die. A perforated viscus is a rupture in the wall of the gastrointestinal tract, leaking its contact into the peritoneal cavity. This is a life-threatening condition. It can be caused by inflammations, infections, malignancies, trauma, bowel ischemias, or obstruction, and peptic ulcer disease. Signs and symptoms: sudden onset, acute abdominal pain and cramping. Wham! Oh, my belly hurts. Nausea, vomiting, chills, fever. It could radiate to the shoulders and cause abdominal bloating. Pre-hospital treatment, IVO2 monitor. Think about pain control. In the ER, they're going to do some labs and images. Some of those images can show 70 to 80% free air under the diaphragm because of the content leaking out. Acute pancreatitis is when the pancreas starts to digest itself. Causes are I get smashed. Idiopathic or unknown cause, gallstones, ethanol, I drink too much alcohol, 90% of the cause, or trauma. Then smash, steroids, mumps, autoimmune diseases, scorpion stings, hyperlipidemia or hypercalcemia, and then ERCP and drugs, antidysrhythmic, antifungal, and seizure drugs. Signs and symptoms are a constant, severe mid-epigastric pain. It radiates straight to the back. There may be Cullen's sign or bruising on the flanks, Gray Turner signs, bruising around your belly button. They may have nausea, vomiting, and a low-grade fever. Pre-hospital treatment, IVO2 monitor, nothing by mouth, NPO. Think about some pain relief and antiemetics. Next is gastroparesis. It's a delayed emptying of the stomach. Most common cause is high levels of blood glucose, which affect the nerves. That vagus nerve becomes damaged after years of high blood glucose levels. Other causes are anorexia, bulimia, Ehlers-Danlos, and Parkinson's disease. So signs and symptoms, most common, chronic nausea and vomiting and abdominal pain. They could complain of palpitations, heart thumping really hard, heartburn, abdominal bloating, loss of appetite, and reflux. Pre-hospital treatment, IVO2 monitor, caca, just like the parrot, and put the patient in the position of comfort. Next is appendicitis. It's caused from infection or a buildup in fluid in the appendix. The appendix could rupture and spill toxins into the peritoneal cavity or the belly, causing peritonitis. So McBurney's point is where your appendix is at. If you draw a line from your belly button to the right iliac crest, 1/3 from that iliac crest is McBurney's point. Some signs and symptoms you're going to have is right lower quadrant pain, fever, nausea, vomiting, and the psoas sign. could help confirm it's an appendicitis. You're going to lay the patient in the left lateral decubitus position, extend their right leg at the hip, and pull it backwards, and that stretch in that right lower quadrant is going to be positive for appendicitis. So most appendicitis is the most common cause of extraureteral pain during pregnancy. So if the pregnant mom complains of right lower quadrant pain, think about appendicitis. Differential diagnoses, they can get an ultrasound or a CT in the hospital. Pre-hospital treatment is IV O2 monitor, pain controls, and antiemetics so they don't puke in your ambulance. Intestinal obstruction. It's an emergent event because if you can't move poo, it's a bad thing. Let's talk about some different types here. You can have a herniation where part of your bowel pokes through a hole in your abdominal wall. Or your bowels could have adhesions stuck together with some scar tissue, which reduces that peristalsis, or that wave-like motion that moves things through your intestines. Then you have an intussusception, where some of that bowel is actually inside of the other. Or you could have a volvulus and it's actually twisted up in a knot. Signs and symptoms, of course, nausea, vomiting. They can complain of pain like crampy, or it feels like their stomach's in a knot. They're unable to pass gas. Their stomach can be distended and firm. Listen to the bowel sounds. You may hear some high-pitched squeaking, or it could be absent. And if you percuss the abdomen, it could be like a hollow sound. In your history, ask them about their appetite and their bowel habits. So pre-hospital treatment, IV O2 monitor. Don't give them anything by mouth, NPO, because they'll probably go to surgery since it's an emergent event. And pain control and antiemetics. Okay, next is abdominal compartment syndrome. How do you get it? Blood in your peritoneum, abdominal trauma, retroperitoneal hemorrhage, blood in there, bowel distensions, well, and you get bowel distensions from massive ascites and fluid in there, liver transplants, pancreatitis, and things like that. Signs and symptoms, that belly is going to be fat and it's going to be tender, tense and tender. They can complain of decreased or difficulty breathing, I should say, DIB, metabolic acidosis. You hook them up to that end-tidal CO2 and they'll be blowing off a lot of CO2. They'll have a declining urine output and could have a decreased cardiac output. Treatment, IV O2 monitor to loosen up the clothing because it's going to be stretched. Be careful of those flying buttons. Avoid fluids, and you can give some diuretics to help get that fluid off of their belly. Acute gastroenteritis is the second leading cause of illness in the United States from fecal-oral route. If you play and poop, wash your hands, doggone it. Wash your hands, wash your hands. So you could have contaminated food or water. Two biggest bugs there are the noro and the rotaviruses that cause gastroenteritis. Signs and symptoms, nausea and vomiting, watery diarrhea, mild abdominal pain, and they could have a low-grade fever. And it could last for 2 to 3 days. Imagine poop and water for 2 to 3 days. That means you're going to be super dehydrated, so fluid resuscitation is what you need. Drink water, drink water, drink water. Pre-hospital treatment, IV O2 monitor, and that fluid resuscitation. And we are to everyone's favorite slide. This was the GI causes of abdominal pain. In the last presentation coming up, I'll cover the rest of the potential abdominal pain issues. Have a good one.